Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for Conversations in Advanced Non-Small Cell Lung Cancer, Rationale and Utility of TROP2 Antibody-Drug Conjugate based on updates from WCLC and ESMO. During this segment, we will be discussing the rationale of ADCs targeting TROP2 and other novel targets. I'm Dr. Benjamin Levy, and I'm Associate Professor of Oncology at Johns Hopkins School of Medicine. And I'm joined today by my colleagues, Dr. Aaron Lisberg and Dr. Alexander Spira. Guys, welcome.
Thank you, Ben, this year.
So let's start out just creating a little bit of a framework here when we start talking about the ADCs. You know, we've come a long way in the field of non-small cell lung cancer with the advent of targeted therapies, the development of immunotherapies, and we've really begun to push the envelope, I think, in the first line. Again, with immunotherapy coming first, targeted therapies coming first, but a lot of challenges in the second line. Alex, you want to talk a little bit about some of the unmet needs, specifically for those patients without actionable alterations in the second line?
Sure. No, happy to, Ben. So I think as I look at it, we've made a lot of headway over the last 5 years in particular, especially since I started 20 years ago in terms of what we have to treat. Immunotherapy has revolutionized the care of oncology patients in the frontline setting, with most patients getting chemo immunotherapy right now in their frontline treatment. And certainly also just looking at chemotherapy with the use of pemetrexed, which has been a very well-tolerated drug, really moved us far along. And again, I remember the days when we were giving 2 drugs with taxanes, which we still do for squamous, and it was tough. The challenge is in the second line setting. We really haven't made much headway, and we're kind of in this status quo for quite some time where the standard of care, the only thing really present on the NCCN guidelines for the second line of therapy is docetaxel. And we all struggle with that because while it's an okay drug, it's only okay. Response rates, plus or minus ramucirumab, are in the 20% range. Pretty tough tolerated drug. I will go out on a limb, I'm sure you will agree with me, that when people are on clinical trials, they do a little bit better, but the real world, it's a very tough drug. Side effects, alopecia, fingernail changes, serositis, very tough drug to give, very limited benefits. So we need to make an improvement for these patients, especially without actionable mutations. We're getting a lot more actionable mutations. I mean, KRAS G12C was the big one from a few years back, but for most of our patients, they still don't have anything beyond that. So trying to get better.
Well summarized. Aaron, do you share Alex's pain with the docetaxel? Are there ways to get patients through docetaxel, dose reductions? Are you doing anything other than docetaxel in the second line off of a clinical trial?
Yeah, I think those are great questions. And I do agree with everything that Alex said. Docetaxel is a difficult drug to use. I found it easier to use with weekly dosing. I think that is better tolerated. And certainly some patients, they can tolerate ramucirumab. That is a reasonable adjunct therapy to give with the docetaxel. But in general, I continue to feel it's a difficult drug to give. I've seen benefit in some patients, but as Alex said, response rates in the low 20%, we're really hoping to do better for our patients.
Yeah, I think the bar is relatively low right now, and we need to do better. We've got all these wonderful therapies like immunotherapy and targeted therapies that we're able to start our patients off on their journey. Unfortunately, we know that most of our patients will develop disease progression, and we are desperate for novel second-line therapies, and that probably sets the foundation for antibody-drug conjugates, or the ADCs, what I call the new kids on the block for non-small cell lung cancer. They're probably the newest class of drugs that we're beginning to look at, evaluate, and leverage in our clinical trials, hopefully in routine clinical care soon. Just a 10,000-foot overview of ADCs. Of course, you have the monoclonal antibody, which should have this high affinity and avidity for the target antigen, be able to conjugate with the linker that can then conjugate with the payload. So the antibody can be chimeric or humanized. It's usually humanized now. And then, of course, the linker, which can be both cleavable or non-cleavable. And we can kind of talk a little bit about that. But the bottom line is non-cleavable needs that lysosomal degradation to disassociate the monoclonal antibody from from the payload, and then the cleavable ones, which are a little bit more flexible in their ability to disassociate the payload from the monoclonal antibody, don't necessarily not just restricted to lysosomal degradation. Again, most ADCs are now using these cleavable linkers. Then you have the payload, and we've, I think, just beginning to scratch the surface on these payloads. We have microtubule inhibitors, DNA damaging agents, topoisomerase 1 inhibitors. Clearly, the payload also has to be amenable to the linker attachment. This all comes down to synthetic biochemistry, the development of these drugs. I mean, it really is the conjugation, the chemical bonds that occur are really important. Aaron, I'll start with you. Are these drugs chemotherapy 2.0 or are they targeted therapy? What are these drugs?
Yeah, I think that's a loaded question, so I will answer it in a nuanced manner. But I think that you've really laid the kind of spectrum in terms of where we can respond here. And, in terms of mechanism of action, as you very nicely described just now, they are chemotherapy agents in terms of how the end results of their actions. But then, are they targeted or are they targeted therapy? I don't know if we can explicitly say that. The way I like to describe this to my patients specifically, because that's where these conversations are usually occurring, is it's more of a directed chemotherapy. We understand that, as you described, that these drugs really only become active when they engage with the tumor cell expression of the target of the antibody-drug conjugate. Then once this drug is brought inside that tumor cell, essentially they become active. So it's more of a directed chemotherapy is how I like to describe it at this point. But I still think it is, at the end of the day, a chemotherapy-like action that's occurring and leading to the tumor cell death.
Alex, your thoughts? I'll ask another loaded question here. Is the efficacy of these drugs linked to the target engagement of the monoclonal antibody, or is it really just all about the payload and the chemotherapy that's linked to that ADC?
Yes, both, I think. So I think you're hitting the target on the cell, right? So if the tumor cells are overexpressing it, but you're also using the payload as well, right? And that's going in and having the cytotoxic effect. I'll echo exactly what Aaron says, but I heard a great analogy. I call it chemo on a stick. So it's very targeted therapy, but you still get, the challenge of the off-target effects. If these are working perfect, you wouldn't have any major toxicity, right? But if you look at many of these, and we're going to talk about this today, we do see some chemotherapy-like side effects. In high enough doses, you get cytopenias. Some of them, for example, things that are conjugated to SM38, which is irinotecan, you get diarrhea-like side effects. You do get alopecia. So in this world of having something that's supposed to be perfect and is only going to the tumor, we still have to watch out for the off-target effects, which can be real.
Yeah, and just, the mechanism of action of these drugs, I think we're still trying to wrestle with. Of course, we talk about target engagement of the antibody, release of the warhead. Aaron, we'll talk about just a little bit about bystander effect, what that's all about with these ADCs.
Of course. Yeah, I think that's a very important concept. And, it's known to be associated with efficacy, and the direct link maybe isn't as clear. But in terms of the bystander effect, essentially, that is the ability for the payload to diffuse through the plasma membrane of a tumor cell to neighboring tumor cells. And the idea there is likely that there may be heterogeneous expression of the target. And so you can imagine within a tumor mass that some of the cells may express the target that this ADC is designed against, and some may not. And the idea being that once the antibody-drug conjugate engages with the tumor expression on those cells that do express the target, the payload is incorporated into the tumor cell, and then it can diffuse through plasma membrane to neighboring cells, maybe that they don't express it, or allowing for those neighboring cells to die as well. So I think that's an important concept, this fusion through the plasma membrane and the bystander effect in terms of the efficacy of these drugs.
Yeah, well stated. And just to add to that, I think we're also thinking that maybe these drugs work through ADCC or antibody-dependent cellular cytotoxicity. Maybe there's an immunotherapy effect here where the monoclonal antibody binds to the antigen and then engages the immune cells to come in and be recruited to the tumor. So a lot of things we're still learning about. Alex, there's a lot of targets out there for ADCCs. There's HER2, there's HER3, there's MET, and there's TROP2. What is the rationale here for TROP2? I mean, we've learned about HER2, maybe mutations and their ability, patients that have HER2 mutations predicting efficacy to trastuzumab deruxtecan. But TROP2 is sort of unwinding on us a little bit, learning about its biological relevance. Any take on TROP2 expression in lung cancer and what it means?
Sure. And I kind of use the analogy, the breast cancer world's a little bit ahead of us, sadly, on this one. But if you look at trastuzumab deruxtecan breast cancer, they first got it approved for very high levels of expression, but now they have, as we all know, great data down to patients who are 1+. Right. So if you look at that patient population, it's huge. And think about that. You just need a little bit. So I kind of lump it into two things. Right. So if you look at things like HER2, when you have HER2 mutations, there's clearly these tumor cells are expressing HER2, but they're mutated and they act as a driver. But now you're looking at something that's just being expressed on the tumor cell. And all you're hoping for in that matter is that it's hopefully more expressed in tumor cells than it is on benign cells. And you can use it as a target or as, if you're thinking about this as a warhead, as a homing device, right? So you're homing it to anything expressing TROP2. The challenge on TROP2, as we'll talk about, is how do you figure out expression, right? If you could figure out which, where cutoffs are and to express things, you could pick out which patients are going to benefit and which patients do not. Great getting an actionable biomarker. We're not there yet for TROP2. That's how I kind of look at it in general. TROP2 is expressed on many tumor cells, bladder, breast, GI, prostate even. The studies are ongoing in these pan-tumor studies right now. Focusing on lung cancer right now, we know that it's very much overexpressed in non-small cell lung cancer, and hence made it right to start doing studies with these TROP2 ADCs.
Yeah, Aaron, you will talk about, you led TROPION-Lung01, looking at datopotamab versus docetaxel. We'll talk about that later. But just any other additional thoughts you have on TROP2, which will kind of lead us into the biomarker question for all these ADCs. But any additional insights about TROP2 and its relevance in non-small cell lung cancer? Do we see it more commonly in squamous cell? Is it more common in non-squamous? Is it going to be a bona fide biomarker for us?
Yeah, those are all good questions. And I'll kind of piggyback on what Alex just said. So, there's a lot of retrospective analyses that have looked at the expression of TROP2 in non-small cell lung cancer, and it's very high. Some data suggests that 100% of adenocarcinoma lung cancers express TROP2, whereas maybe the number in squamous is 92%, which essentially means that across the spectrum, we're seeing expression. Now, in terms of high expression, maybe the numbers are lower, about 2/3 of cells. But we do have data from the phase 1 trial looking at our non-small cell lung cancer patients treated with Dato-DXd, the TROP2 agent. And we're really not seeing a clear correlation between TROP2 expression on the tumor cell surface and response. So at this point, certainly that is not an appropriate biomarker, and it was not an inclusion factor for the trials. Patients were enrolled irrespective of their TROP2 expression level. Importantly, the trials were designed with pre-treatment biopsies, oftentimes on-treatment biopsies, and sometimes even post-treatment biopsies to help us move this question forward and identify a more clear biomarker. But at this time, I think we have to accept the idea that TROP2 is expressed by the vast majority of non-small cell lung cancers, and that the specific expression is not clearly correlated with response.
Great answer. So Alex, Spira, I don't get it. If these ADCs target the antigen on the cell surface, it would seem like the more antigen you have, i.e. high expression, the more likely are these drugs to work. But we're not seeing that. So this gets down to the final part of this segment here, which is all, just a broad discussion about biomarkers and the unfair question to you, which is why doesn't overexpression of a protein thus far predict efficacy to these drugs? We've not only seen this with the with trastuzumab deruxtecan and HER2 overexpress. We've seen that HER3 expression doesn't seem to matter for patritumab deruxtecan. We've seen that TROP2 overexpression doesn't matter for datopotamab deruxtecan. What gives? Do you have any good explanations for this as to why this is happening? And if IHC is not the biomarker, where should we go here?
Gee, Ben, give me an easier question there. People have been trying to figure this out for a long time. So I think number one is, you struggle just in developing a biomarker assay, right? I mean, you have to laugh a little bit. What we look at in HER2 for breast cancer is 1+, 2+, 3+. And yeah, while there's good ways of designing that, I mean, that's essentially a pathologist looking at, there's a little, a medium, or a lot. And I know that's a way of understating it, but that's not a very good way of doing things. We're all scientists here. We like to think in numbers and percentages and cutoffs and what to do and fish testing and copy numbers. That's literally eyeballs. So that already tells you that looking at these IHC assays is not very good. Is this just a function of the assay, right? Are we just not able to do the assay due to expression and the reagents that we're using, right? I mean, not everything is amenable to an assay. Or does it have something more than that? Is it density of the TROP2 on the cells? Is it two of them sitting next to each other? What does it mean to be overexpressed? I don't think there's a good answer to that. And the reason I get an easy answer to this is there's been a lot of minds smarter than me. Since TROP2 was being studied, since these ADCs first came into clinical trial use a few years ago, everybody's been trying really hard, and nobody understands it. Nobody understands how to build a better mousetrap right now, unfortunately.
Great answer. That's probably the best answer I've heard from you in a long time. Not that you don't give good answers, you do, but that was really, really tight and succinct, and I liked it. I think, again, we just don't have a real understanding of this, and we need more work in this space to define who's going to respond, and not only that, how to predict toxicity. So thank you again for joining us for this segment on the rationale for ADCs targeting TROP2 and other novel targets in advanced non-small cell lung cancer. Please be sure to click on the landing page for this activity to claim your continuing education credit, access supplemental slides, as well as other topic segments.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.